All right, so medications for diabetes. The first thing we want to talk about is hypo and hyperglycemia. So hypo or low blood sugar, you're going to have tachycardia, an increased risk incidence of sweating, also known as diaphoresis, shakiness. If they feel cold or clammy, that means they need candy. We have hyperglycemia, which is going to be known as our 3Ps: polydipsia, polyphagia, and polyuria. So polydipsia, meaning increased thirst, polyphagia, meaning increased hunger, and polyuria, meaning increased urination. The first two meds that we're going to talk about are going to be our sulfonylureas and our meglitinides. Our sulfonylureas are our glipizide. A big thing to remember about these drugs, they have sulfa and the start of them. These are sulfa drugs, so if you have someone who has a sulfa allergy, they cannot have these drugs. Riplinide is another one. That's our meglitide. Both of these cause low blood sugar, because if our goal is to lower the blood sugar, we can always lower it too much. And then it can cause nausea, vomiting, and diarrhea, which is normal. No alcohol use with these, and using a beta blocker, which is a heart medication that we talk about later in the semester, can mask the effects of hypoglycemia. So we'll talk about that a little more when we get to cardiac meds, but just keep that nugget in the back of your head. The next one is probably the more common. This is our drug of choice for type 2 diabetes. It is metformin, our biguanides. We have side effects of anorexia, nausea, vomiting, diarrhea, and weight loss. This is why it's one of our more popular drugs, because it causes weight loss instead of weight gain. Another side effect is lactic acidosis, not alkalosis, acidosis. That comes from renal impairment, so we do not want to use these with renal dysfunction medications. No alcohol with these meds. And the big thing that causes the lactic acidosis is contrast dye. This is really big in ATI. So we want to discontinue 24 to 48 hours before we receive the contrast, and then we will restart it after 48 hours if we have normal kidney function. If we do not have normal kidney function, we will not start the med back up. Next, we have our pioglitazones. This is going to cause fluid retention, high cholesterol, and hepatotoxicity. So this one's not one that we like to use a whole lot because of the increased cholesterol. When we have someone who is a type 2 diabetic, we want them to lose weight, not gain weight. And we want them to have lower cholesterol, not higher cholesterol. So we want to make sure that we're really monitoring those cholesterol levels. We're monitoring for signs and symptoms of fluid retention, like edema and weight gain. And we're monitoring for signs and symptoms of liver toxicity, nausea, vomiting, anorexia, jaundice, that darkened urine, or lightened or clay-colored stools. The next one we have is our Archbos. This one can cause iron deficiency anemia, so we need to monitor our red blood cells, monitor our iron levels, and maybe increase and provide supplemental iron. It is hepatotoxic, which we know what that means. And then hypoglycemia, it can cause low blood sugar, so we have to monitor that. Okay. Insulin. Insulin is typically given sub-Q. The only insulin that can be given into the vein is going to be our short-acting regular insulin. Rapid is going to be our Lispro. Short acting is going to be our regular. Intermediate is going to be our NPH. And long acting is going to be our Glargine. Insulin that can be mixed include NPH and regular. Week 6, we're going to go up to the lab and do those. Our rules of mixing include cloudy to clear. So we're going to inject air into the NPH. Then we're going to inject air into the short acting. And then we're going to withdraw the clear or short acting into the syringe, and then we're going to withdraw the cloudy or the NPH into the syringe. You should have done that last semester in fundamentals, and you'll be doing it this coming week in our lab as well. Big thing to remember is that nothing can be mixed with long acting. It has to be given by itself. So then we have our non-insulin injectables. We have our pramlintide. The biggest thing is it can cause some nausea and some irritation, so we want to rotate the sites. We can get, with our exenatide, we can get pancreatitis, so we want to notify the provider of abdominal pain. It's important to report that because it could be a sign of pancreatitis. Okay, so now we have medications for other endocrine issues. We're going to start with the thyroid. So key symptoms to remember for hypothyroidism: drowsiness, depression, bradycardia, and cold intolerance, meaning that they're cold all the time. And then hyperthyroidism, anxiety, tachycardia, palpitations, heat intolerance, meaning they're hot all the time, sweating, and fever. So medications to treat hypothyroidism is our levothyroxine. It's used to treat low thyroid. So we can have an adverse effect of hyperthyroidism where we over-medicate them. So we need to monitor for that. And we cannot take them with any kind of antacids or any kind of GI meds. It should be taken on an empty stomach, first thing in the morning, with just a sip of water. To treat our hyperthyroidism, we're going to use methimazole or propylthiouracil or PTU. Our adverse effects, the first thing that we can do is cause a overdose, over medication, which can cause us to bring the thyroid too low and give us hypothyroidism. We can have agranulocytosis, which is that decrease in white blood cells, so we are at high risk for infection. So we need to monitor things like sore throat, fever, fatigue, things like that. And then lastly, it can cause hepatotoxicity, so that's going to be where we monitor for our signs of liver failure. Another thing that I see in ATI lot, PTU, starts with a P and is safe in pregnancy. So that's important. The other one is not. Okay. Moving on to our antidiuretic hormone, we have our vasopressin, which will treat diabetes insipidus. Side effects include water intoxication, so that could be things like a pounding headache, sleepiness. With that vasopressin, it is pressing on our vascular system, so we can have things like heart issues, stroke, high blood pressure. So if we have a cardiac patient, we do not want them to take this. And then we have our adrenal replacement hormones, which are our glucocorticoids. We've already talked about these 100 times. They stay pretty much the same. We're at risk for osteoporosis, infection, and hyperglycemia. So monitor for signs and symptoms of infection, adrenal suppression, fatigue, muscle weakness, nausea, vomiting, confusion. And we want to taper the dose. Remember, we talked about Miss Greenbaum feeling like crap in Disney World because she didn't taper her glucocorticoids. So that's it in your packet. The other thing I want to remind you to look at is our iodine, our radioactive iodine for high thyroid, and our non-radioactive iodine. So just kind of take a peek at those. And that is it for our endocrine tutoring.